Assalamu alaikum, everybody. Just going to wait 2-3 minutes more. So if anybody else wants to join us, then I'm going to start the meeting. I intentionally started 5 minutes late. I thought most participants joined a bit late, so I started a bit late. But anyhow, we'll just wait for a couple of minutes more, then we'll start. Today, in addition to covering OPG, we'll also be covering two other X-rays that were suggested by participants. We're going to be briefly talking about occlusal X-rays and xylography. So, occlusal X-rays actually come under the heading of intraoral X-rays, but again, just due to the request, I'm including them in this session. We'll just talk briefly about it. What are the types of occlusal X-rays? What are they used for? And then briefly we'll talk about xylography briefly, not too much in detail. And then we'll move on to our main topic, which is OPG. So we have quite a few things to cover up, and it doesn't look like anybody else will be joining us today. So I think I'll start, and then we'll see if anybody joins us along the way. If not, I'll be sharing the recordings shortly after the session is done. All right, so coming to occlusal X-rays. Occlusal X-rays are X-ray technique in which the X-ray film, or PSP stands for photostimulable phosphor plate. Basically, I don't know if the participants in this course have taken the oral radiology course I did during the COVID pandemic. In that, I talked about what are the different type of X-ray films or receptors that we have. Basically, you have the films which are developed via chemical processing and which are usually available in our dental colleges, hospitals, and even clinics. But nowadays, the trend is gradually shifting towards having digital films or digital receptors in which you can take an X-ray and you can just view it on your laptop. So there are two types of image receptors in that regard. One is called a PSP, and one is called the charged coupled device. It's called CCD. So both are quite useful in doing recording intraoral X-rays. The PSP is basically it's sort of a hard film. It's a film like the normal X-ray that you're seeing in front of you, but instead of opening that, it is sort of an X-ray that you can reuse. I think about maybe a few hundred times or a few thousand times, for getting it correctly. But then that is something you don't have to dispose of. Basically, it's not like there is a separate film for every patient. You wrap up this PSP film in an X-ray sleeve or cling film, so you can reuse it on a different patient. And then it has its own machine which interprets that X-ray, and you just connect that to your laptop, and then that gives you the image that you want to see. For most of the time, I've seen it being used with a mobile intraoral scanner or with a mobile X-ray generator. Anyhow, if this is appearing confusing, I think what I'll do is I'll share a few pictures of that later on in the group. Anyhow, basically, you can either use a plain X-ray film that you have in most of our hospitals, or you can have a PSP, which is placed in the occlusal plane. So you can see you have different sizes of X-rays over here. You have the adult PA, where also used for the bite wing. It's called number 2. And this is also used for carrying out occlusal X-rays in children. Number 1 is the adult anterior periapical X-ray. For children, size 0 is used for periapicals as well as bite wings. And if you want an extra long bite wing, you can use the number 3. Or if you want to do an occlusal in adults, then you use the number 4. All right. So you have different X-ray sizes. I know in Pakistan, we just use one X-ray for everything. But there are overseas, you have different sizes of the films for different population according to their age. All right. So how do we classify occlusal X-rays? Well, they're classified based on which jaw you are utilizing, you want to visualize. So for the maxillary occlusal, and you have the mandibular occlusal. So you have then 3 separate subtypes. For the maxillary occlusal, there is one called an anterior occlusal, in which you can see the anterior teeth very prominently, and that is taken at 45 degrees. Then you have an upper standard occlusal, in which you can sort of see the entire maxillary arch from the occlusal point of view, and that is taken at 65-degree tilt. And then you have an upper oblique occlusal, which is done for the posterior teeth and for the posterior maxilla, and this is done at a 60-degree tilt. Now, coming to the mandibular occlusal, you have further 3 types. You have the lower 90-degree occlusal, you have a lower 45-degree occlusal, and you have a lower oblique occlusal. So the 90-degree occlusal gives you a sort of an overview of the entire mandibular arch. The lower 45-degree occlusal is basically sort of like the anterior occlusal, shows you the anterior teeth quite well. And the lower oblique occlusal is basically done for detecting stones in the submandibular gland. I can also give you a rough idea of the posterior dentition, but those usually do not appear very clear on this X-ray. Let's just see a couple of pictures of these occlusals, but first let's discuss a few indications. So what do we do occlusals for, basically? Well, they are done to locate supernumerary, unerupted, or impacted teeth. You can use it to locate foreign bodies. You can identify extent of tumors, although obviously CT or CBCT is much better in this regard. You can also monitor changes in the mid-palatal suture during orthodontic treatment. You can use it to detect siloliths. You can use it to evaluate the maxillary sinus, although still not very well. It can aid in the radiographic examination of patients with trismus. Well, and that much is obvious. When a patient cannot open their mouth, you cannot do intraoral X-rays for such a patient. And let's suppose you are working in an area where you don't have an access to an OPG machine, or your OPG machine is faulty for some reason. So then the second thing that you can do is perform occlusal X-rays for that patient, and hopefully they can tell you if there is any tooth which might be the cause of the trismus. And the lower occlusals, these are also useful in locating the displacement of fractures in an anterior-posterior direction. So here we have the upper anterior occlusal. As you can see the upper central incisors, lateral incisors, and canine quite well in this picture. It's almost as if you're looking at two periapicals of the upper canine to canine region. So this is done, as you can see, with the occlusal X-ray lying between the patient's teeth, and the X-ray beam is fired through the nose at a 45-degree angle. So as you can see, if this patient, let's suppose, could not open his mouth and he had some problem in the anterior maxilla you wanted to evaluate, so you can, instead of relying on an OPG, you can just do an upper anterior occlusal. Now, this is the upper standard occlusal or the tomographic view of the maxilla. So in this, as you can see, the X-ray beam angulation is now 65 degrees in comparison to 45 degrees in the anterior occlusal. Patient is again biting on the occlusal X-ray between the teeth. The direction of the X-ray beam is now 65 degrees. And this thing that you see over here, this is basically the thyroid collar. All right. So this is done to prevent radiation towards the thyroid gland. So now in this, you can see the occlusal aspect of almost the entire maxilla. It's almost as if you were It's almost as if you're looking at the axial view of a CT scan of the maxilla in this region. So this can give you a rough overview of the entire maxilla, right? Okay, so another thing you would have noted that although you can evaluate the maxillary anterior teeth somewhat so quite well with an occlusal X-ray, you can't really evaluate the maxillary posterior dentition. Well, for that reason, we have an upper oblique occlusal X-ray, and this is basically done for the premolars and the molars. And this obviously has to be done separately for both sides. So in this patient, as you can see, they're doing it for the left side. So here you can see an impacted tooth over here. You can also see the D and E over here. So these can help you somewhat in locating any pathology in the maxillary posterior teeth. So the angulation is roughly the same 65-degree angle, but now the entry point of this X-ray is now held at round about 2 centimeters below the lateral canthus of the eye, and the angulation is roughly the same. All right. So this covers the maxillary occlusals. Now let's move on to the mandibular occlusals. So this is the tomographic view of the mandible, or the lower standard occlusal for the mandible. As you can see, again, the X-ray receptor is held between the teeth in the occlusal plane, and you fire the X-ray beam through the chin and almost at a 90-degree angle to the X-ray film. The patient, for this purpose, obviously the patient's head has to be tilted extremely backwards. However, one modification that I do personally in this case, where if a patient cannot flex their head that much, is that you just simply tilt the X-ray beam, pointing it completely upwards, and you just ask the patients to put their chin on top of this X-ray beam. So for that, they may have to get out of the dental chair or do the standing up. It's because usually our X-ray generators cannot bend down to such a level so that they can be performed in the chair. So they may have to get up for this. So, but this is one modification I can suggest to you, which will work in patients who have, let's suppose, some neck issues in which they cannot flex extend their neck that much, or if you're suspecting some sort of neck injury to a patient, and you want to do this just to evaluate displacement of the fractures in the mandibular symphysis area. So, and you want to do an occlusal. So this is one technique that you can do, which will not require neck extension. All right. Okay. So then we have the lower anterior occlusal, and this again is an X-ray which is in which you can see the canine to canine region of the mandible quite clearly. So in this again, the X-ray receptor is placed between the teeth, and now the X-ray beam is fired at a 45-degree angle through the chin, and this is the resulting view that you will be able to see. Again, you will note that you cannot evaluate the posterior teeth very clearly in this X-ray. However, you can see some caries over here in this teeth. All right, coming to the last occlusal X-ray, well, this is the lower oblique occlusal. So this X-ray is basically done if you want to evaluate any siloliths in the submandibular gland, especially if they are lying posterior or if they're near the hilum of the gland. So this is an useful X-ray in that regard. You would obviously know that if you do an OPG for a patient in which you do in which you are suspecting a submandibular silolith, the mandibular bone will obstruct views of the silolith. Even if it is calcified, it's quite hard to see unless the stone is present quite inferiorly to the mandible. Then you might be able to pick it up. But if it's present in the duct, you can't pick it up on an OPG. So if you can't, if the stone is lying in the duct, you can either do a tomographic occlusal, or if you suspect it's lying somewhat posteriorly, and let's suppose the patient is gagging and the car won't allow you to place the X-ray film that so posteriorly that you can view it on a tomographic view of the mandible. So then you can do this oblique view of the mandibular occlusal X-ray. So in this, you will hopefully be able to pick up a stone if it is calcified. All right. So that brings us to the end on occlusal X-rays. So if there are any questions, I'll take them now. Otherwise, I'll move on to the silography. Anything that's not clear? One indication that I told you guys about the occlusal films was if you were investigating a patient who has trismus. But another indication is also if a patient has severe gag reflex and does not allow placement of the intraoral films inside his mouth and just causing him or her to gag. So you can do occlusal X-rays for such patient, and these are quite helpful in this regard as well. So this is something that you can do to help the patient. All right, we have a question here. The X-ray beam represents the angles in like 40. Yes, there you basically have to tilt the X-ray beam because in almost all of the views other than the mandibular tomographic view, the patient's head does not move. All right, its patient head has to be parallel to the Frankfurt horizontal or parallel to the floor, basically. So in most cases, the X-ray beam angle is like 45-degree. In the upper occlusals, it was 65 and etc. But otherwise, it's mostly 45. And you're most welcome, Dr. Sagwa. It was a very good session. I thought these are quite useful things for one to know, even with regards to generally practicing or for exam purposes. So thank you for the session. All right. So I guess if we don't have any more questions, I'll move on to conventional silography. All right. The thing about silography that you should know is that it has several types, and it basically whenever you order a xylogram for a patient in which you suspect submandibular or a parotid stone, is that xylogram depends on what facilities the radiology department has for conducting the xylogram. Because as you can see, you have various types of xylography which are available. To my knowledge, whenever we have sent a patient for xylography, they have always come back with the conventional view, or in which basically they just take plain X-rays of the submandibular gland after they have given the contrast agent. However, mostly the other method is usually used, which is the fluoroscopic method, and this is the one which is mostly done outside in the developed countries. However, you also have the option of doing it via CT or CBCT, or even doing the MRI, in which you can evaluate the xylogram. The best indication for an MR xylogram is that whenever you don't want to give contrast to the patient, or let's suppose when the patient has an allergy to the contrast agent, or he's planned for radioactive iodine treatment of the thyroid gland for thyroid cancer. So those are the best indications for MR xylogram, because in this you don't have to give a contrast agent. All right. In an MR xylogram, what they do is they basically opt for sequences in which the sort of saliva in a way acts like a contrast agent. Okay. So you can do a xylogram in such select cases, and it's not done very routinely. The problem with an MR xylogram would obviously be if a patient has anything which is magnetic in their mouth or in their the rest of their body, like a pacemaker, etc. All right. So you can also do a CT or CBCT xylogram, but if the patient has amalgam fillings or has a crown and bridge in their mouth, so that will cause metal-related artifacts whenever a CT is done. So that greatly distorts the image, and you won't be able to properly see the results of your xylogram. So usually CT or CBCT xylogram is usually not done. This is the reason why conventional or fluoroscopic methods are done a lot more routinely. All right. So gold standard nowadays, which I asked a couple of radiologists, is the fluoroscopic method, and obviously before that, and something which is still routinely done in Pakistan, is the conventional method. All right. So there are some technical points which you should know whenever you are ordering the xylogram. Is that whenever you suspect a patient has come to you with an acute or chronic inflammation of those glands, so you cannot order a xylogram straight away. All right. And the reason being that the gland is already inflamed, and whenever you're injecting contrast into the gland, that can cause spread of the infection towards the hilum or even into the body of the gland. And it is there is slight discomfort whenever you inject contrast agent. Basically, whenever a radiographer is doing a xylogram, there is no standard volume that you have to give as contrast. It's basically you keep giving the amount of volume, which can range from 0.5 to even 3 ml. Is by whenever the patient notes that now his gland is becoming distended or it's becoming slightly tender. So if you inject contrast into an already inflamed gland, so you won't be able to, the patient will very quickly tell you that, now my gland is hurting, don't give me any more contrast. So the study will not yield any useful information, because you can't give the full amount of contrast that you're supposed to give. So that patient should be given a course of antibiotics for 7 days pre-op, and then continue it for 3 days post-operatively. All right. For this, you usually a 22 or a 24 gauge IV cannula is used. However, on a couple of YouTube videos, I saw a specific cannula which was called a xylogram cannula, which is sort of C-shaped, so it can enter the gland anatomy quite easily. The reason being, especially for the submandibular glands, is that we have a question how I'm coming to that, Dr. Sabha, about how the dye is injected. This dye is injected via this cannula, basically. I think I'll probably have to share a video of the technique, so probably you'll have a better idea of how it's done. But I'll try to explain it here the best as I can. Basically, the first step is that you have to locate the orifice of the gland, like the Stenson's or the Stenson or the Wharton's duct. We can locate that first just by clinical examination. However, if it is not very clear to you, then you can do a couple of things. Number one, the patient has to be quite well hydrated. If the patient is not well hydrated, then you cannot manually, press the duct for expulsion of saliva. So that will give you an idea where the orifice is located. So if he's dehydrated, and this method will not work. So you have to keep the patient well hydrated. There's no concept of NBM in such cases. These procedures are done under in an OT, but without any anesthesia as such. Second of all, if you're still having trouble, then you can give the patient some citrus foods like lemons or oranges to increase the amount of salivary flow. So once you've located the orifice of the duct, the second step you have to do is you take usually a lacrimal probe, a Bowen's probe basically, and you use it to sort of just slowly enter the orifice of the duct, and you move it in circular motion so the duct orifice becomes enlarged. All right. When you enlarge the orifice of the duct, then passing the angiocatheter into the duct becomes a little bit more easy. All right. So once you do that, after that you can insert the angiocatheter. You can do it via an IV cannula, but according to some videos that I was looking up in preparation for this webinar, they suggested using a specific xylogram cannula. They called it a Ferruccia cannula, but I tried looking it up exactly, but I couldn't find anything by this spelling. Maybe I'll have to recheck the video about what exactly they called it. So it's basically sort of a C-shaped cannula, and the C-shape helps you, navigate the curvatures of the gland duct, basically. If you recall your anatomy, you would know that the submandibular gland duct has two constrictions. One is near the orifice of the duct, and the other is near the hilum of the duct. So if you are trying to pass a straight cannula into the duct, it will be quite difficult. So this C-shaped cannula, this basically helps you navigate that constricture, and it makes it sort of easy to cannulate the duct orifice. All right. So once you have done that, then water-based iodinated contrast agents are used. The same agents are used which are used in CT scans. You can use diatrizoate. You can also use iohexol. Any iodinated contrast agent can be given. It is better to use the water-based one because oil-based contrast agents are difficult for the gland to remove. So water-based ones are easily soluble and can easily even travel through the duct, and they are easily removed as well. So books, especially Tucker, recommends that you use water-based contrast agents whenever you're doing xylography. So the volume they have mentioned is 0.5 to 1 ml. However, it depends on the size of the gland. You may even be required to administer up to 3 ml of contrast agent. Okay. So coming to the phases, xylography basically occurs in 3 phases. These phases are ductal, acinar, and evacuation phase. All right. So ductal phase, it occurs immediately after you've given the contrast. So immediately whenever you've given the contrast, you take the first X-ray at this point to see if the duct, if the contrast agent can travel through the duct or not, and is there any obstruction present in the duct or not. All right. So once you've done that, the second phase you start after a couple of minutes, and that is the SNR phase. Basically, you know, the submandibular gland or any salivary gland is made up of various SNI. All right, this SNI is the basic secretory unit of a salivary gland. So within minutes, if there is no obstruction, then the ductal phase will end, and the contrast agent will enter the SNI of the gland, and you should be able to visualize that. Okay. After 5 minutes of your contrast has been given, the gland should be able to remove the contrast agent by secreting saliva and removing the contrast through the duct orifice. So this within 5 minutes it should be done. If you don't see any contrast after 5 minutes inside the gland, it means that the secretory function of the gland is fine. However, if you're still seeing contrast in areas of the gland, even after 5 minutes, it shows you that there is probably still an obstruction over here, or there is decreased secretory function of the salivary gland. All right. So I'm just going to show you a couple of pictures of these phases of xylography. Now, this is the first phase. As you can see, this is a xylogram done of the submandibular gland. So you can see the duct. It's a nice, beautiful, long, uniformly thick duct. So it's showing you that there's probably no obstruction during the ductal phase. All right. So ductal phase appears to be fine. In fact, the contrast agent has now even gone into the SNI. Can you see these small white branches over here? So these are the first order. Then you have here are the second order SNI. So you are beginning to see the start of the SNR phase as well. All right. So the first X-ray that was taken, that was it shows you at least that there is nothing wrong in the duct of the salivary gland. Now here is the second X-ray that has been taken. Now this is the SNR phase. All right. So you can see that this whole submandibular gland has now sort of lighted up like a Christmas tree with various lights, etc. So all these small branches that you are seeing over here, this is normal. This is how a salivary gland with normal functioning SNI, which have no obstruction, this is how it's supposed to look like. All right. So this is a normal SNR study of the submandibular gland. So this is what should happen after a couple of minutes. And finally, then this is your evacuation phase. Now, I told you in an evacuation phase, you are supposed to see no contrast agent after 5 minutes. You are seeing that most of the contrast agent has been removed, but you are seeing some patches where it hasn't. So this is telling you that probably in this area, there is some pouching off has been made, or this lumen of the duct has increased in these areas where the contrast agent is now sort of staying and it's not getting removed. All right. So this is what an evacuation phase of the submandibular gland or of a xylogram should look like. Okay. Okay. No, not after every 5 minutes. The first X-ray that you will do, that is done immediately after you give a contrast. All right, within like 5 to 10 seconds, you're supposed to do the X-ray. Then after a minute or two, then you should do the second X-ray, which is for the SNR phase. And the last X-ray you have to do after 5 minutes, which is done to assess how the evacuation phase is going on. All right. So probably within 5 minutes, you have to do 3 X-rays for the patient. All right. Immediately after 1 to 2 minutes, and then after 5 minutes. Okay. So this is for conventional xylography. All right. This is not for fluoroscopic. I'll tell you very roughly what fluoroscopic is, and but I'm talking about conventional xylography over here. All right. So now let's come over here. Okay. So this can either of you tell me, what do you see in this xylogram? What phase do you think you're looking at? And is there anything you see which might raise your concern? Anybody? SNR phase. Yes, you are beginning to see the start of the SNR phase. Basically, in the SNR phase, the whole contrast has supposed to come into the ductal phase, has supposed to come down from the ductal phase. So you are still seeing contrast in the ductal phase, and you're beginning to see the start of the SNR phase over here. All right. But don't you see that there is here the contrast agent is coming here? You have this break in the contrast, and then you have this enlargement of the gland, and the duct of the gland, and then the contrast is continuing again. All right. So this is basically a stone in the submandibular gland. All right. Through the stone, basically the submandibular gland will not allow contrast to pass very easily through this area. So that's why that area will look devoid of contrast. All right. Wherever there is a xylolith, there in that place you will not see contrast, or you will see very thin band of contrast over here, like you can see a little bit over here. Okay. So here you do not see any contrast, and because of the presence of the stone, the gland is now, the duct is a bit enlarged over here, and then the rest of the phase is going on completely. Dr. Pulvasha, I'm sorry I'm not getting your question. Can I point it in a mid right? I'm sorry I'm not getting your question. Are you talking about me pointing in the mid right of this? I hope you can clarify what you meant. This is the stone. Just follow my cursor over here, all right? This is the stone, all right? Just follow my cursor over here. So this is the stone. Wherever you don't see filling of the contrast, that area is an area of obstruction, basically. All right. So, like I said, stones don't necessarily have to be calcified. They can be uncalcified stones. So that's why you probably won't see increased radiopacity in this area. Okay. That's why we usually do a xylogram, because we can't detect a non-occlusal X-rays. Okay. Okay. Coming to the next one. Okay. So which gland has undergone a xylogram in this one? Can anybody point it out?
Parotid.
Yes, this is basically the parotid gland. So as you know, its entry point is opposite of the upper maxillary second molar. So you are seeing basically this all this area up till here. This is that catheter. All right. So over here, basically here is the entry point. Here is the parotid papilla, if you would say, and here is the rest of the duct. And anything you can see over here?
प्लीज ये वापस बता दें जो अभी बताया आपने डॉक्टर साहब, ये पापिला वगैरह.
ये parotid papilla, it lies basically on opposite the maxillary second molar. So I was saying that all this area that you are seeing over here, this is not the duct. This is basically the catheter that you have inserted into the gland, into the duct, sorry. So this is carrying that contrast agent, and it is present in this area over here. All right. So basically duct आपकी यहाँ से start हो रही है. I'm saying this is not the duct. This is that catheter that you have put in. Okay.
Okay.
All right. Achha, we have less than a minute into the meeting, so if you guys can quickly tell me what this picture is showing you, then I'll have to restart it, and we can देन मूव ऑन अहेड। जी, तो इसमें कुछ नजर आ रहा है आप लोगों को? Any filling defects